This is going to be just chapter 19, teaching and learning. So we're going to start with teaching and learning. So when we talk about teaching our patients, this is part of an independent nursing practice. The basic purpose of teaching and learning is to provide information that will empower our patients and their families. Would be things about performing self-care, making informed decisions about their healthcare options. Like other interventions, you can use teaching to promote wellness, prevent or limit illness, restore health, adapt changes in body function, and facilitate coping with stress, illness, and loss. A&A standards. For teaching, the registered nurse seeks knowledge and competence that reflects current nursing practice and promotes futuristic thinking. Registered nurses' teaching activities include providing health, teaching that addresses such topics as healthy lifestyle, risk-reducing behaviors, developmental needs, activities of daily living, and preventative health. Uses health promotion and health teaching methods appropriate to the situation and the patient's values, beliefs, health practices, developmental level, learning needs, readiness and ability to learn, language preference, spirituality, culture, and socioeconomic status. You should seek opportunities for feedback and evaluation of the effectiveness of the strategies used. We should use information technologies to communicate health promotion and disease prevention information to the healthcare consumers in a variety of settings. Provides healthcare consumers with information about the intended effects and potential adverse effects of the proposed therapies. Patients, participants in healthcare decisions, patient care providers expect patients to take an active role in making decisions about their health. Patients and families need information so that they can make informed decisions. We can help patients get answers to their questions, find resources, recognize problems, and develop self-care behaviors. Our hospital stays are becoming brief, and us as nurses have the responsibility to teach family members and patients how to provide care and to teach how they are capable and able to do things for themselves. Healthcare is expensive. Patient education can help to decrease the overall cost of healthcare. It does so by helping increase patients' understanding and compliance with medical and nursing regimens. And that can shorten hospital stays and reduce readmissions. And when we talked about this in class, we talked about, I believe, like teaching diabetics appropriate dietary measures and how, if they follow those and they understand those, they'll have less readmissions or complications for their diabetes. And that was just everything that we just talked about. So the three domains of learning, when we talk about learning, is cognitive. And cognitive includes storing and recalling information in the brain, ranging from simple to complex processes. This encompasses 6 levels of behavior, which is memorization, recall, comprehension, analysis, synthesis, application, and evaluation of ideas. Strategies and tools to support teaching cognitive type content includes lectures, reading materials, panel discussions, audiovisual materials, program instructions, and problem-based learnings, like case studies and care plans. Hands-on skills require a psychomotor learning. These are learning a skill that requires both mental and physical activity. It requires the learner to accept the value and knowledge of the skill. Strategies and tools used to teach psychomotor skills include demonstration and return demonstration, simulation modules, audiovisual materials, journaling and self-reflection, and printing. An example of this would be when we teach a patient to do a blood sugar. We would give them an example and then they would have to demonstrate that back to us. Effective strategies and tools for promoting effective learning include role modeling, group work, panel discussion, role playing, digital storytelling, mentoring, one-on-one counseling, and discussion of audiovisual materials. The best would be using a combination of them, like educating the patient about using an EpiPen and having them be able to give it back. So our learning theories. We have our social learning theory, which explains the characteristics of the learner. Self-efficacy is a major concept in social learning theory. It refers to a person's perceived ability to successfully perform a task. Next, we have our behavioral learning theory. This is characterized by explicit identification of information to be taught and implemented with an immediate reward for a correct response. It has roots in psychology and the belief that the environment influences behavior and in fact is an essential factor in determining human action. And Pavlov was one of the big theorists on this, where he had those dogs and whenever he'd ring a bell, he'd give them a treat, and it got to the point where if the dogs just heard the bell, they would salivate because they were ready for that treat. The last one, or the next one, would be cognitive learning. And this is seeing learning as a complex cognitive, which is mental activity. Learning is as intellectual or thinking process in which learner structures and processes information. Cognitive theory also recognizes the importance of developmental stage and social, emotional, and affective influences on learning. And the last one is humanism, which focuses equally on the learning's affective or emotional state, as well as their cognitive intellectual state and their attitudinal qualities. It influences the learner's active participation and responsibility in the learning process. Learning is thought as self-motivated, self-initiated, and self-evaluated. And its purpose is self-development and achievement of the learner's full potential. So we have our 5 rights of teaching. So our 5 rights of teaching is the right time. But is the learner ready? Are they free of pain and anxiety? Are they awake from a restful nap, or are they tired? Then it's our right context. Context in this is the environment quiet, free of disturbances? Is it private? Is it soothing or stimulating? Our goal. Is the learner actively involved in planning the learning objectives? Are you and the patient both committed to reaching mutually set goals of learning that achieve the desired behavior changes? We have our right context, and this is that the content is appropriate for the client's needs. It's new information or reinforcement of the information that's already been provided. Does the content relate to the learner's life? Is it otherwise relevant to them? So we want to make sure that we're preparing content that is appropriate to what's going on. We don't want to be talking about diabetes to somebody who isn't even a diabetic. And if we're having a problem motivating our patients, sometimes providing them content of what will happen if they do not do the recommended therapy is a good strategy to help them understand why the content could be read if they don't understand. And then we have our right method. So do the teaching strategies fit the learning style of the learner? Do the strategies fit their ability to learn? Is this patient able to read and write and we're giving them pamphlets, or are they illiterate and therefore pamphlets would not be the correct method? Are they able to read and write but they forgot their reading glasses? So if they don't have their reading glasses, is giving them something to read going to be the correct method? So factors that can affect our clients' learning would be motivation. Again, your motivation, this is the desire from within. It's created by an idea, a physical need, or emotion. Motivation is greatest when the client recognizes the need for learning. So if the client believes it's possible to improve their health, they're going to be more motivated. If you tell them what could happen, that would be a motivation as well. Are they ready to learn? Right? This is determination of the behaviors that indicate the learner is both motivated and able to learn at a specific time. Things that could impact our readiness to learn could be a physical condition, like, do they have the strength? Do they have the energy? Do they have the sense of mobility? And then it's emotion. If somebody's having severe anxiety or stress or emotional pain, that can all interfere with their ability to learn. Mild anxiety can actually create an enhanced learning. Timing. People are trained information better when they have an opportunity to use it soon after it's presented. So if we're going to be doing, let's say, education on taking a blood sugar, it would be good to do that education and have that patient demonstrate how they take their blood sugar right before lunchtime, where they're going to be doing it, versus in the middle of night, when in the next day would be the first time that they would have an opportunity to use those skills observed. We have active involvement, and that's learning is more meaningful when the client is actively engaged in planning and learning activities. Learners retain 10% of what they read, but they retain 90% of what they speak and do. Feedback given. Positive feedback encourages learners and boosts morale when it comes to tackling difficult content and devoting the time and effort needed to get the most out of the educational process. Repetition. The client is more likely to retain information and incorporate it into his or her life if the content is repeated. Learning environments. Again, an ideal learning environment is private, it's quiet, it's physically and psychologically comfortable, and it's free from distractions. Scheduling of the session. We want to plan for uninterrupted time to allow us to adequately assess the understanding of the patient. The teaching time does not need to be long, just uninterrupted, based on the patient's condition. Shorter teaching sessions may be best for comprehension and retention. Amount of complexity of content. The more complex or detailed the content, the more difficult it is for people to learn and retain. In addition, the greater the change, the greater it is the challenge for both the teacher and client. Teacher-learner communication. Barriers to communication include pain, anxiety, fatigue, illness, hunger, and many other things. So we need to limit our distractions, and we need to make sure that if we're having somebody who's hearing impaired or visually impaired, that we're using the appropriate communication techniques. Our special population. The adaptations we need to make will depend on the nature of the special need. If we are not familiar with the patient's condition, we must acquire theoretical knowledge of it. Include a family member, caregiver, or significant person in the teaching to reinforce the learning and act as a safety net for implementing the information. Developmental stage. An understanding of intellectual development will help us to gear our teaching strategies and content to the level of the learner. Culture. The cultural sensitivity involves respect for the client's identity and needs, regardless of who they are, where they're from, how they speak, how they are, what religion they practice or not, whether they're disabled or not, how much wealth or poverty they experience, how much they weigh, how socially popular they are, or any other aspect that can lead to unfair treatment. And then health literacy. This is the ability to understand basic health information and services needed to make appropriate healthcare decisions. On the contrary, health illiteracy occurs when the language spoken is not the patient's preferred language. In light of a high number of people in the United States who cannot read or write English, reading literacy is yet another significant barrier interfering with communication between patients and healthcare providers. Barriers to teaching and learning are different for the teacher versus learning, and then it can be compounded by our technology. So barriers for your teacher, and remember, you're the nurse, so you're going to be the teacher, would be the competing demands of the nurse. We don't have the time. So dedicating time to teaching can be difficult. We can have conflicting schedules between the nurse's availability for teaching and the patient's available time for learning. Remember, we want to make sure that the patient's awake, well rested, there's no interruptions. But if that time of day is conflicting with the time that we have to give meds to other patients, it's going to create a barrier for us actually accomplishing that teaching. We have ineffective coordination of class lecture with lecture experience, lack of space and privacy. Teaching's not seen necessarily as a priority, especially by the different organizations that you'll be working for. There's no third-party reimbursement for teaching. And what that means is that the hospital's not rated by the Centers for Medicare and Medicaid, or they're not rated by the Joint Commission on their ability to provide teaching. So a lot of organizations do not stress teaching as the priority because there's that lack of reimbursement. And then it's frustration with the amount of documentation. So when we teach our patients, we need to document everything that we teach, and that can be very time consuming, which again falls back onto the competing demands on the nurse's time. Our barriers for the learner include the illness and fatigue and other physical conditions they're experiencing during hospital stays, the anxiety and personal stresses that they have, low literacy and low health literacy, environment not conducive to learning, right? We have multiple doctors that are coming in and out. We have the lab, we have dietary, we have case management, physical therapy, occupational therapy. So it all creates environments that are not necessarily conducive to learning. We have a lack of time in the learner's best potential for learning. We have an overwhelming amount of behavioral changes needed and an overwhelming complexity of their conditions. There's often a lack of support and ongoing positive reinforcement, a lack of motivation, which is willingness to be responsible. We have language barriers. We have teaching that's not suited to learning preferences and styles of the patient. We have providers' use of jargon and technical terms. And we have patients that do not perceive the need for the information that they're told. And then the barriers to technology-based learning is that we have the lack of social interaction, we have poor learner motivation, diverse learning styles, time issues, technical problems that arise from our software and our devices. And we have access to the internet that can be affected. And again, if you think about the fact that we have limited time to teach as nurses, and then we might have a technical problem with the software device, it makes it even harder to get that education to the patient. So that's how I meant in the beginning with the compounding of technology, making it harder for teachers and harder for learners. All right, so the components of the learning assessment. So when we're doing a learning assessment, we should include the following. Who's our attended audience? Who are we teaching to? What's the person's age, occupation, developmental level? What's their cultural affiliations? Will the teaching be a one-on-one or will it be a group? And then we have the learning needs. What's the client's medical or other problem? What behavioral changes are needed? What self-care knowledge or skills does the patient need? Moving on, we have our knowledge level. We need to determine what the client or patient already knows so that we can reinforce knowledge or adapt the teaching plan to the patient's actual needs. So we need to ask questions like, what do you think caused this healthcare problem? What are your concerns about it? How has the problem affected your usual activities? We need to ascertain information about their health beliefs and practices. We need to ask them to give a general description of their health. What do you usually do to stay healthy? What problems do you think you're at risk for? What lifestyle changes would you be willing to make in order to improve your health? We need to know we need to assess their physical readiness. So check their ability to concentrate, to do manual dexterity skills, and their pain level. We need to assess what their emotional readiness is. Find out whether the client is experiencing anxiety or emotional distress that will interfere with their learning process. Ask the patient whether she would like a family member or friends to be present during the learning. We need to assess their ability to learn. What's this learner's cognitive and psychomotor developmental abilities? How does the patient learn best? Are they better with memorization or recall, or are they a problem solver, somebody that wants to apply the information? How well does the patient recall previously presented material? We want to assess their healthcare literacy level. Does the patient have the ability to understand basic health information and services needed to make the appropriate healthcare decision? Can the person read and write? Does the patient and the healthcare provider speak the same language? We also want to assess their neurosensory. What is the patient's ability to feel, see, hear, grasp? Does the client have any medical conditions that cause neurosensory compromise? And finally, we need to assess their learning styles. Ask the person, how do you prefer to learn new things? Do you want to read about them? Do you want to watch about them? Do you want to listen to me talk about them? Do you even like to read? Where do you typically get your information from? Do you like the internet? Do you like magazines? Do you prefer just information directly from your doctor or your family? Do you learn best alone, or do you need to be in a group of people? These are all things that we as the nurse would want to assess. And then we can develop our diagnosis. So our diagnosis for this patient would be a knowledge deficit. Knowledge deficit is the most frequently used nursing diagnosis for teaching plans. We should use knowledge deficit if we believe that the lack of knowledge is the primary problem. So when we're planning our outcomes, we can sometimes plan a learning contract. A learning contract is a statement of understanding between the teacher and the learner about how to achieve mutually set goals. The contract usually describes the responsibility of the teacher and the learner, a time frame for teaching, content to be included, and expectations of the participants. Learning contracts increase the learner's commitment to reaching the teaching and behavioral goals. They're usually informal. So you're not going to have a patient actually sign a contract, but we're going to come up with a contract including that information. Our teaching goals are broad in scope and set down what is expected as the final outcome as teaching and learning process. They should address all three domains of learning. And then our learning objectives are single specific behaviors that must be completed to accomplish the goal. They are short term and ideally are accomplished in 1 or 2 sessions. Similar to patient outcomes in the nursing process, learning objective goals should include an action verb, an activity that can be measured or observed, the circumstance, the learner's performance, and how the learning will be measured. So the components to a teaching plan. We're developing a teaching plan. We need to have teaching strategies. These are methods used to present the content. Examples include lecture demonstration, return demonstration, one-on-one instruction, and mentoring. Content included from the information your learner must understand to reach the desired goal. It can include facts, skills, or emotion. Scheduling and sequencing. As a general rule, we should present simple topics before complex and non-threatening topics before controversial ones. We should also determine when the teaching session should be scheduled based on the patient's and the teacher's needs. When extensive content is involved, it's best to schedule a teaching session in advance. The teacher and learner are then committed and prepared for this session. Using small amounts of time can be effective when teaching is brief and organized. And then instructional materials. What tools are we going to use to introduce the information and reinforce the learning? So some examples of teaching strategies would be lecture. Lectures are efficient and cost-effective ways to impart information, especially in large groups, and it does not allow for individualized learning or teaching. So lecture of audiovisual is good for large groups. Then we can have group discussions. So group discussions will be several participants discuss topics, exchange information, and present their viewpoints. The teacher acts as a facilitator to achieve objectives shared with the group at the beginning of the session. Effective group discussions require an atmosphere of trust that encourages everyone to participate, openness to new ideas, and confidentiality of content expressed. One type of group discussion is brainstorming, which involves process of generating multiple ideas for problem solving. You might be part of group discussions if a unit you work on is having an identified barrier to an HCAP, which would be your patient survey. And everybody would sit around and say, well, I think, we could do these things to help with privacy. That could be an example of a group discussion. Demonstration and return. This is when the teacher explains and demonstrates a skill or a task. The learner then demonstrates comprehension by returning the demonstration. Return demonstration should be scheduled close to the initial teaching of the skill. This format allows for targeted questions and answers and practical matters rather than theory. This method requires the demonstrator to have specialized expertise if highly technical skills are involved. And I use the blood sugar or insulin injections for the example for that. One-to-one instructors and mentoring. One teacher presents information to an individual learner. So when we do our test reviews, so that's me teaching you one-on-one. And then we have our digital source for information. So your digital source for information may include streaming video or flash format, computer animations, audio clips, film slides, and things of that nature. They can be effective supplements to other methods if the teaching session is followed by question and answer sessions and discussion of content. So we do a lot of digital information during lab where we give you the video and then we discuss and we do more after we watch the video. And then we have our printed materials. These may be available in a form of sheets, discharge instructions, printed pamphlets. Your client's literacy level must be assessed before you hand out pamphlets to make sure that it's appropriate for their learning ability. Role modeling would be acting in a way, in a manner that our patient would then act in. Role modeling would be more seen if you were precepting or being precepted, you would role model that person's behavior. And then online source of information would be learners can obtain extensive information and support geared towards lay public as well as healthcare professionals via the internet. These electronic learning platforms offer education through multimedia, search engines, electronic libraries, blogs, and so forth. We just need to make sure that we encourage them to use accredited sites. So even though your book talks about blogs, we know that blogs are not necessarily accredited or audited, so the information on them can be false or invalid. So we want to gear them towards things like the CDC and Mayo Clinic that we know are credible source of information. So after we present our information, we need to evaluate, did the learner really understand what we gave them? And one way we can do this is by oral questions, interviews, and questionnaires. We can obtain more information by talking to our clients. However, it's sometimes hard to get an honest response. So if we do an anonymously written evaluation, we can get a true, honest evaluation of how it went. Direct observation. So direct observation, we can help in providing feedback, either to reinforce accurate learning or to correct misinformation. So when we're in lab and we show you a video about maybe an injection, and then we watch you do an injection, we can do a direct observation to say, okay, your location for your needle is not appropriate. So we can correct that immediately. And then we have our clients' reports and our clients' records. So we can evaluate the data and given feedback. We can provide a criteria and clear explanation to help with the client's documents. And then we have tests and written exercises. So tests and written exercises can be used in formal learning settings to measure retention and progress towards meeting our objectives. This method requires learners to have adequate literacy skills. And that would be the conclusion of this particular Zoom, and I'm going to do a secondary link for promoting health. So thank you for watching.